Dr. Ronnie, interventional cardiologist at Wilton Park, Kansas at the Smalling Vascular Institute. I would like to thank Dr. Craig Walker for inviting me to speak at this NCVH Digital Education Series. It's my honor and pleasure to give a presentation on what I've learned about chronic venous insufficiency and refluxing perforator veins as an interventional cardiologist, I think as an interventional vein therapist. I have no relevant conflict of interest. Chronic venous insufficiency, or CVI. We'll jump right into it. For years, it's been a long-standing premise that cancer and its associated therapeutics is primarily the cause of lymphedema, whereas CVI is often overlooked as a potential cause of lymphedema. In the retrospective clinical analysis conducted by Dean et al., it was found that CVI, not cancer or cancer therapeutics, is the cause of lymphedema, meaning the primary disease was chronic venous insufficiency causing lymphedema. The study cohort of 440 patients who underwent decongestant lymphatic physiotherapy at a university's medical center's cancer-based physiotherapy. Chronic venous insufficiency was responsible for 41.8% of the cases of lower extremity edema, while cancer itself is attributed to about 33.9% of lymphedema causes. If we look at the different subgroups that were established in the study, there were 4: cancer, CVI, lymphedema, and primary. This study, published in the Journal of Vascular Surgery in 2020, revealed that lymphedema diagnosis with a primary or patients with both CVI and lymphedema, and other patients for the study cohort along with their associated percentages of patients who suffer with lymphedema and other comorbidities of cancer. CVI, 440 patient cases, was demonstrated in 41.8% of the patients in the study and were diagnosed with CVI, while cancer attributed to about 33.9% of the lymphedema cases. As many patients present with multiple causes of lymphedema, whereas diagnoses have demonstrated that lymphedema coexists with other described causes, more than one cause. Now, if we look also at the EVRA trial, a randomized trial early in the venous ablation and venous ulceration done in the UK, venous disease or chronic CVI is a prominent cause of venous ulceration according to many studies, and traditionally compression therapy has been used to treat venous ulcers, oftentimes as the primary treatment. While the compression therapy improves or manages CVI, allowing venous ulcers to heal sometimes, however, compression does not treat the underlying cause of venous hypertension. In this groundbreaking randomized trial, the EVRA trial, outlining how early endovenous ablation led to healing of ulcers and was more cost-effective and quicker as compared to the other groups of venous leg ulcer patients. Time for ulcer healing, an important factor in VL use, was found to be shorter in the early intervention group, wherein the superficial reflux was treated expeditiously after 2 weeks of randomization, as compared to the deferred interventional group, which were considered for ablation procedure after the ulcer had healed or after 6 months after randomization. The conclusion was that early endovenous ablation of superficial venous reflux resulted in faster healing of venous leg ulcers and more time free from ulcers than the deferred endovenous ablation. I would like to bring attention to Dr. Marlon Shull's presidential address at the 2019 American Vein and Lymphatic Society Annual Congress. The title of his talk was Under Treatment, not Over Treatment, but Under Treatment of Venous Disease, a novel concept. As per the Improving Wisely data in the AVLS, nearly 3,582 venous leg ulcer patients who received an ablation basically 2% of those diagnosed with venous leg ulcers. Dr. Schul explained the importance and need to discuss the problem of undertreatment of venous leg ulcers despite the present concern of overtreatment of venous insufficiency. Guidelines, he felt that we need to build more benchmarks and three consistent studies indicating median intervention rate of only 1.6 to 1.7 ablations per patient. Multi-societal initiatives need to be undertaken to increase the importance of this treatment numbers. Multi-societal initiatives increase access to care, increase provider competence. We need to bring the providers and the payers up to speed in terms of what the numbers are, what's available, and which patients are not being effectively treated. This is a journal of vascular surgery study by Dr. Peter Lawrence, a long-time investigator looking at venous ulcers from June of 2011. It's very important because it shows that in subgroups of patients with recalcitrant ulcers, which did not heal despite optimal compression and ablation of the refluxing truncal veins, saphenous veins, knowledge is that there is indeed a benefit from incompetent perforator vein ablation, in addition to the truncal ablation. The journal study found successful ablation increased to 90% with repeated ablations as compared to 58% in the initial procedures. 90% ulcers healed with at least one perforator closure, while no ulcer healed without a minimum of one perforator vein treated. If we look at the diagram of venous perforator reflux, it is believed that perforator veins are one of the prominent underlying causes of venous reflux and recurrent venous disease. Such veins are more common in patients with skin changes, and particularly in those with ulcers. Venous leg ulcers located most often in the lower calf and ankle region, called the gator region. It is suggested that incompetent perforator veins should have reflux duration of greater than or equal to 0.5 seconds and are more often greater than 3.5 millimeters in diameter, indicating these particular veins, the perforator veins, are pathological and should be subsequently treated. Endovenous ablation of the lower extremity veins is one of the primary treatment means for symptomatic venous reflux disease. Endovenous heat-induced thrombosis, however, and recanalizations are potential complications of these procedures. In this study of 10,029 procedures were performed between March 2012 and September 2018 on 8,273 perforated veins, with 6,091 being treated with RFA, 3,938 were treated with EVLT. It was found that even though there was a relatively higher chance of EHIT and recanalization in the age group of greater than 8 years of age, in the study, it showed that a majority of EHIT were only class 1 or class 2 EHIT complications. Thus, according to the study, majority of venous ablation procedures are safe, effective across all age groups, and age alone cannot be used to deny patients venous ablations. Improving these patients is extremely rewarding, and many are able to ambulate independently, where once they needed assistance. The cost-effective analysis of EVRA trial, early versus deferred endovenous treatment of superficial venous reflux in patients with venous leg ulcers or VLUs. This is a UK study, and the venous ablation revealed that early venous ablation treatment of new venous ulcers was found to be more effective than late intervention treatment for venous leg ulcers. These statistics show incredible savings to England's healthcare system, despite the overall cost of the healthcare ablation, the venous ablation. There was an overall offsetting advantage of a much lower overall healthcare cost. Early endovenous intervention is highly likely to be cost-effective with 89% probability at a threshold of 20,000 British pounds. per quality adjusted life year. Incompetent tributary veins, sometimes not felt to be important. Residual incompetent tributary veins that come off of the perforator vein after vein surgery increase the need for reintervention after 6 years if they were not treated at the time of perforated vein closure. Recently, it's been posted venous ablation treatment in the presence of incompetent tributary veins has a greater chance of leaving an incompetent truncal is more important than leaving an incompetent truncal vein untreated. There's an underlying risk of increase in reintervention if not all incompetent truncal veins are targeted. Treatment of superficial and perforator and deep vein stenosis include healing of chronic venous leg ulcers. Usually when venous ulcers fail to heal despite compression therapy, their incompetent superficial perforated veins are ablated. The study found that both correction of superficial truncal vein reflux as well as correcting the deep vein stenosis contributed to healing of venous leg ulcers. Thus, patients whose ulcers failed to heal after superficial and perforator vein ablation should have their iliocaval iliofemoral vein system imaged to identify hemodynamic abnormalities or significant stenosis, very amenable to stenting. It facilitates venous healing even in patients with large ulcers. In conclusion, patients with venous ulcers who fail to heal with the standard ablation of incompetent superficial perforating veins benefit if deep vein stenosis are identified. Ablation of incompetent superficial veins to stent vein stenosis further improves ulcer healing. This is a diagram showing the mechanism by which iliac vein compression syndrome occurs. As the left and right iliac veins come from the legs to form the inferior vena cava, the left iliac vein, the left common and external iliac vein come up underneath the right iliac artery, coming off the aortic on the right leg. With the vertebral bodies of the lumbar vertebrae, with the right iliac artery coming across one or both of the iliac veins, it's easy to see that compression of the iliac vein can occur. So evaluating this can be done initially with a duplex ultrasound of the iliac veins to look at the size as well as looking at the phasicity of Doppler flow pattern versus a continuous venous flow without respiratory variation in patients who have iliac vein compression. Diagnostic studies also, such as CT venography or MR venography, can be performed, but venography with IVUS, intravascular ultrasound, followed by iliac vein stenting, can be performed in a single setting. If we look at some of the new exciting iliofemoral stents that have been approved, Efficacy or Boston Scientific stent was approved in May of 2019. De novo by BD Interventional, March of 2019. The wall stent was actually formally recognized and given FDA approval, even though it's been used for decades in an off-label fashion to treat iliofemoral stenosis. And recently, June of this year, 2020, the Medtronic iliofemoral stent was approved. If we look at basically just a couple of points on the trials for the IDE trials for the Efficacy, the Venous stent, the trial was called Virtuous. There was 170 patients. There was both post-thrombotic, 75%, and non-thrombotic, 25% subgroup patients. The mean lesion length was 111 millimeters. The mean stent length 149 millimeters. The median stent length was 120. Early efficacy, 12-month patency, primary patency was 84%, 79.8% of the post-thrombotic, it's 96.2% of the non-thrombotic. And the 30-day freedom from major adverse events was 98.8%. If you look at the de novo venous stent in the vernacular trial, 170 patients, it was a combination, half and half, of post-thrombotic and non-thrombotic. The median stent length was not reported. The efficacy endpoint indicates that the 12-month primary patency was 88.3% combined. Broken out, close thrombotic was 81.3%, and the non-thrombotic was 96.9%. Overall freedom from MAE was 93.5%. I'd like to thank you for the opportunity to share with you some of the exciting advances in studies we've seen in this last year. And I'd like to thank Dr. Walker again for the opportunity to present at the New Cardiovascular Horizons Digital Education Series. Thank you. Have a great day.